New Year to one and all. I know we're 2 weeks in, but I'm got no holds barred about saying it. So happy New Year to one and all, and welcome to the call. Super excited to be kicking off our first webinar of the year with some new faces in the chat, it seems, and a stellar cast from our end. Speaking to you, Max.
Thank you.
First and foremost, I'd love to see how far we're reaching with these webinars, just to get a feel for it. I ask it every week or every month, but north, south, east, west, could you pop in your chat where your location is and we can see who's winning the medals there as well? Scotland, Wales, we've had a couple of, South very general, Ray. You can do better than that. Cheshire, okay. East Mids, woo, woo, woo. Wales, Joe, you're winning everything today. Bristol, goodness me. Okay, we're getting a bit detailed now. I'm going to have to get the old maps out, possibly even VAR, to see if we can beat any old records. But really, really pleased to have such a geographical spread on the call. It's really good to see. So keep it up and thank you for being here. Now, a quick poll just to see who's been paying attention to today's topic. I'd love to hear how you're feeling about AI generally. It's in the press a lot. People are speaking about it a lot. I went on LinkedIn yesterday. My entire feed was dedicated to AI, which is slightly scary. So here's the poll. A 1 in the chat if you are entirely terrified. The thought of it helping with AI in primary care terrifies you to death. Just a 1 in the chat. A 2 if you can't wait for AI to take some of the pressure off your day-to-day workload. And a number 3 if it's a little bit of both. If you're a little bit excited, a little bit anxious, I'd love to hear from you. So that's a 1 for terrified, a 2 for excited, and a 3 for both. Fair few 3s in there. A bold Andrew with a number 2. Worried about IG. Okay. Is that Instagram? I don't know. We'll get to it. Anyway. So whichever way your cookie crumbles, I think we're going to have a good chat today. And I'm hoping that today's topic and conversation is going to spark further conversation. Thank you, Debbie. I was only joking. Jeepers. Awesome. Right. Bit of housekeeping before we get going. Firstly, to say the call is going to be recorded for prosperity and sharing, so you're not going to miss a thing if you need to drop off at any point. We know that you're all busy. We're aiming to keep you for no more than 30 minutes, so just bear that in mind, Max. Second of all, we love the questions, so please feel free to drop those into the chat at any point, and I will get to them when we can. And we do like to keep this man on his toes, so keep them really spicy. My name's Lucy Glynn. I'm the community manager here at Exxon Health, and I am delighted to welcome Mr. Max Gatlin back to the hot seat to join us today. Good day to you, sir. How are you?
Good morning. I'm good, thank you. It's taken a while to try and condense what we have into 30 minutes, so it's worth noting that anybody can reach out to me at any time if you want any more information. I will be touching on IG, we'll be touching on technical architecture, our approach to AI holistically, but of course it's all going to be surface level. So if you want to dive deeper with me, please do reach out.
Yeah, I know. Apologise for rambling on at the beginning, Max. I think that was me getting told off everybody, but you know, let's get back in his box. I think it's fair to say that we are right on point with today's topic, aren't we? This month's webinar theme is very much the topic of the moment. Very nice of Sir Keir, I think, to jump in the news and promote our subject matter this week as well, I think. But let's get to the nitty gritty, Max. Here's the big question. How can we use AI to ease pressure on primary care?
It's a very good question. We know that AI is having an impact on every industry, you know, and I think it can be quite daunting, the impact of AI. I know there's lots of press in the news around different levels of AI, types of AI and approaches to AI and how we use it. So for the next 25 minutes, I at least want to dive in and just show that we don't have to go, don't have to dive into the deep end and you know, share everything around the world and kind of not understand where our data is or anything like that. There are very tight, controlled, supervised ways that we can train and leverage AI to reduce the current pressures that we have and future pressures that we have in primary care. So what we'll go through today is I just want to spend the first 10 minutes just kind of digesting that a little bit about the types of AI and levels of AI, how what data is accessed by artificial intelligence and how we can control that in such a controlled way. And then for the second segment, I'd like to show you some examples of AI and how we've applied it to primary care. And then, of course, I've got, in true Exxon Health style, one good example of an AI product that's now come to market. So I'll spend just 5 minutes on that before we go to some questions, which I hope there's lots of towards the end. So I'll try and stick to the Deadline of 10:30, may spill over slightly, but without further ado, let's jump in. So firstly, what is artificial intelligence? I'm not going to read from the screen, but we had a fantastic AI day with Exxon Health in London, of which Pritesh Mistry from the King's Fund attended, and he summarized it really well. But it's essentially a system that performs tasks requiring human intelligence, such as decision-making, problem-solving, and learning. That is the holistic view of AI. And actually, Andy Main from Somerset NHS Foundation Trust, with his paper on artificial intelligence briefing across that trust, he gave us a good kind of Venn diagram, if you like, if that's the right use of the word, of the different disciplines of AI. So AI is a very broad term. You may hear lots of different kind of artificial intelligence jargon or terminology when you're reading the newspaper or your LinkedIn feeds, but it's really important to note there are subsets of AI. So when we talk about it, we're talking about it holistically, but today I'll show you how we can go and just view those different types or subsets and how we can apply it to primary care to ease those pressures, to answer your question, Lucy. And if you haven't seen the briefing paper by Andy Main from Somerset NHS Foundation Trust, I'm sure that we could find a link and pop it in the chat or send it out in a follow-up email. Sorry to put you on the spot there, Lucy.
No, I appreciate that. I'm on it.
Perfect. So first, we'll look at the types of artificial intelligence. You may have heard of large language models. So these are models trained on vast amounts of data. A very kind of common household example of this is probably ChatGPT, run by a company, OpenAI, and we're currently using that within primary care, or using it in all industries to summarize notes, for example, to speed up the note-taking within clinical time, to make the most out of your 10-minute appointments, which was a really strong outcome from our AI data. And I'm not saying that GPs are going into ChatGPT. It's not. There's other products that are layered over it to ensure that it's contained, constrained, and safe to use. And that's why I've put OpenAI in brackets there, because OpenAI is the actual AI model it's all trained on. You then have generative AI or Gen AI, and that creates new content or solutions based on patterns. So it's being used by DeepMind to predict protein structures. And then agentic AI is kind of this autonomous decision-making artificial intelligence. Now, I'm showing you the breadth of all of the different types of artificial intelligence, but it's not to scare you. It's just to let you know that we can just focus on large language models, and they can have a huge impact on the work we're currently doing within primary care and help ease that pressure. So I just want to focus your mind to the left of the screen, where we could just leverage large language models to reduce health inequalities, improve access to healthcare services, redesign care pathways. There's lots of work that we can do, as well as transcription and clinical note summarization. So yeah, I'm showing you everything, but just focus on the LLMs at the moment, because that will unlock a lot of benefits of the AI. So on that same strand, then there's also, and again, Andy Main put this in a very good way, and I'd love to use it, and that's why I'm crediting him for everything on these two slides. So the first kind of level of AI would be narrow. So this is AI that focuses on one specific task and can do it as well as a human can. I think Andy referenced Face ID, with NHS login or iPhones. It's very simple. It does the work that a human might need to do to verify who somebody is, and we're already using that technology within primary care. The next level up, you could say, would be general, so smart as a human, but able to automate multiple tasks at once. And then super, it'd be smarter than a human in every way possible, is the term that Andy used. We can also look at, it's not just categorizing AI, whether it's narrow, general, or super in terms of its intelligence, but also how it's trained, so the data it's trained with. So the first level of training would be supervised AI, so where it's taught with examples. You show the AI what you want it to do, or how you want it to act, and it acts accordingly based on that set of training data. The next level up might be unsupervised, where it looks at patterns and it can detect unusual activity, like, again, bank accounts. We've all had our card potentially frozen due to maybe overspending or lots of traveling, and you have to contact the bank to unlock it. That would be an AI that's monitoring that activity. And then reinforcement, where actually you're unleashing the AI, if you like, to allow it to trial something, make a mistake, and then retrain itself. So that would be reinforcement. And I just, again, like the previous slide, I just want to let you know that in order to ease pressure in primary care, we don't have to overcomplicate it. We can use narrow, supervised, AI models to help us support with our daily tasks. And again, I'll show you some more examples of those as we go on. But you will see lots of different artificial intelligence. We've all seen the sci-fi movies. We're all, watching the news, and sometimes it feels like we're in a bit of a sci-fi movie. But I think our approach to AI within. Go on, Lucy. Sorry, is there a question?
No, I was just laughing at your point. It does feel a little bit like you're in some kind of Armageddon-based
it kind
movie
of,
at the moment.
You're absolutely right. It takes you back to iRobot.
But yeah, oh gosh, don't. But now that you have brought me into the conversation, I am intrigued. So have you got any examples of this in action? Narrow and supervised sort of AI.
Yeah, absolutely. So I'll come on to those I've got a couple of slides to get through, and I'll come on to some examples. There's some amazing, brilliant companies out there. You've probably all seen them popped up. Now all the trade shows, kind of half of them have been taken up by these AI products. So there's lots of products out there. I just think it's important to note, how are they leveraging AI? We shouldn't be turning away from those stands. We should be embracing it, and focusing on the challenges that they're helping us overcome. So it's not so much what type of AI they're using. Yes, it's helpful to understand this, but really we need to focus within primary care. Okay, what's my challenge now, or my predicted challenge in 12 months to 24 months? And how can we leverage AI and lean in to get all of our governance and documentation right? And then we can spend the money or line up, get our ducks in a row and line up the right resources to make sure that AI tool can serve or solve our problems. So great question, Lucy, and I will come on to those a little bit later. But there's lots out there. So speaking more broadly, AI isn't new. Well, you could say it's relatively new in the grand scheme of things, but it's already in use in healthcare. You could look at dermatology, radiology, predicting activity and predicting emissions. But again, I could go on all day about AI uses that already exist within healthcare. Okay, so it's being used. I just think what we need to do is just bring it down a little bit and understand, right, what are our pressures in primary care, and how could AI support those pressures? Which I kind of got ahead of myself on the previous slide, but we're all very much aware. We've got rising patient demand, dwindling resources within the surgery, and this could be any. I know we're now looking at lots of data around the loss of GPs. We're losing GPs by numbers, but actually it's the whole workforce in its entirety within primary care. And I believe that we could leverage AI in certain places to solve those problems, because yes, I know we're feeling the pinch now, but it's going to get much worse in the next 12 months, 2 years, or you could say 3 to 5 years, if we don't act and embrace technology like artificial intelligence now. And I'll refer back to Andy Main and his team's work on the AI briefing paper within the NHS Somerset Foundation Trust. They do reference in there all of the ethical considerations, how you should safely approach it, what you should and shouldn't do, and how transparent you should be, not just as a user of the artificial intelligence, but also as a supplier as well, which is our role to make sure everything is kept safe and secure. Did we get a link, Lucy, to that paper?
I've popped a link to a page which kind of summarizes the event that you've referenced a couple of times, Max, and about halfway down that page there's a bunch of resources, including the Somerset paper that you've made reference to. So yes, it's in the chat, and I will send it out with the link for the recording as well.
Perfect. And just springing back to, I'm going to give an example of this actually in a moment, but springing back to the use of large language models where you can train it on a data set. And then think about what Pratesh said from the King's Fund around AI is basically when it can carry out a human task and obviously succeed a large amount of the time. So what we can actually do by combining those is, if we think about, okay, so I've got 5, 6 receptionists on, and I've got a huge surge at 8 a.m. in the morning. And then if we look at the data around, 40% of those requests coming from patients may be an admin request. And we've looked at data. That's about right if you look at it. Lots of which can be done online, self-serving. But actually, if we build the right model and the tool, and we can actually train it in a supervised and constrained way, so thinking back to the narrow supervised model, we can basically speak to a reception team, get all of the questions they might get all of the answers, upload all of that data, train the LLM. And actually, if you look at the bottom of how AI can help on this slide, we can train it in English, and what artificial intelligence will be able to do is understand a patient's language. So they type in their own primary language, and actually it could translate the question and the response that a receptionist wouldn't be able to do. So actually, And what that would do, obviously, is because the AI would be available 24/7, those patients can self-serve in their own time, 10 p.m. on a Tuesday, 9 p.m. on a Saturday, and the patient could get the right support that they need. And instantly, you'd see a reduction in the need for 5 or 6 receptionists. So what we would do is we would train 2, 3, 4 of those receptionists in other roles within the surgery and have them focus on preventative and proactive care. So it's about using, it's more, I mean, I think that AI will solve the inefficiencies of digital products within primary care very quickly. And actually what that might lead to, if we've got these amazing tools that have solved all the digital inefficiencies, you may get human inefficiencies. So then you can retrain, and that's where we get the reallocation of staff. And we can send our staff on training days to teach them, to expand their skill set and do other roles within the surgery. And then if they are focusing on preventative care and their follow-ups, the call and recalls, you can then look at your QOF points and get a healthier population. And overall, by embracing all of this technology, give it a few years, we'll have a healthier nation. And then we can reduce that patient demand that's coming in, reduce hospital admissions into secondary care. So it's really important, I believe, that if we can leverage technology to kind of execute those human actions within the surgery, or even before it gets to the surgery, then we can better utilize our humans that are in the surgery. And even then, you've got improved workforce well-being, etc.
Yeah, I think that's a really valuable point, because one of the objections I hear quite a lot is, well, we don't want AI to replace humans, whether that be from a clinician point of view or an admin member of staff. And I think that's a really valuable point, that this is actually freeing up people to do proactive care in line with the 10-year plan and in line with everyone's sort of wants and needs. I think that's a really, really important thing to highlight, Max. So thank you for doing so.
No problem at all. And I think that there's a couple of examples that I can actually give that we do need to focus on within primary care, and this should land well with everybody. We would like to reduce patient demand, and there's now AI products out there that could support with that. I've just given a pretty good example of a virtual assistant that might be able to support in multiple languages. It would understand when there's typos. So it's not like it's a Google search or anything like that. We can train the AI and it can actually understand where there's a typo, correct it, and give the appropriate response. Transcription, there's already a bit of a typo there. I think it was format or form. So we're working, it's actually a speech to text kind of point I wanted to make there. Again, thinking about digital inequalities, we want to offer equity of access to all, whether it's text, voice, digital, non-digital, it should be standardized. And what AI is helping us to do is actually now allow patients to complete forms by voice, so via the phone, and that can complete a form for those total triage surgeries here. That could complete, for example, an AccuRx form or something of the like. We've also got in the form of transcription about clinical note-taking, so within consultations. I referenced it very quickly at the start. And this was an outcome of one of the great discussions with the GPs at the AI event in London with Exxon Health, was it's giving the clinician more time to speak to the patient and understand within that 10 minutes. So they're actually getting 9 minutes of consultation, 1 minute of note taking. And I actually think it's slightly less than that with some of the GPs and how they're using it, but it's a really important note to take away. We can improve outcomes, so predictive analytics, lots of work happening in Exxon Health and other companies around the country, leading into, and again, we mentioned it there, Lucy, around how can we get better use out of the humans, not just the technology. We don't want the tech or AI to replace humans. It won't. It will just enable humans to do their job better. So it'll understand cohorts of patients better. It'll be able to identify health needs in certain areas and population health management, and then actually can have the human element of outreach. So it could follow up and contact those people. So if we manage the inbound better, automated with AI, we can focus on the outbound with a human touch where we need to. And in the future, you may be able to automate that if the humans need other roles in the task, but we won't get too ahead of ourselves. There's lots of things that we can do right now. Improved comms is a very, very simple one. I've used it in my professional career for the last couple of years. If you need any support in writing or understanding or learning or training, we can use LLMs to support us. Service design and predictive analytics, which again, I touched on a little bit in the previous one.
Yeah.
So Sorry,
Go on,
Lucy.
Max. I was actually just going to say, and I think you've answered my question. A lot of this sort of feels quite futuristic, but one of the things we put in the lead up to this webinar was, it's here and now. So I'm intrigued to see what happens next.
Thank you. So yeah, I promised an example of one tool. And again, for each of these kind of 6 sections or uses, these are all available now in the marketplace. Yes, I think somebody referenced IG and compliance and governance. I'll come on to that if I've got some time at the end. I've got a couple of slides. So as long as it's safe, clinically verified, DTAC approved, etc., there are tools out there now that can help you ease that pressure in your surgery. And again, I'm more than happy to have conversations with anybody that has.
Max, you've just muted yourself magically. Wasn't AI, was it?
Oh, did you hear what I said on the previous slide?
I heard half of it, and then all of a sudden you went on mute.
Okay.
So let's. I'm sure it was very valuable. Let's march on.
Yes, no problem. So, yeah, what I was saying on the previous slide was there's examples of and products out there for all 6 of those segments we showed on the previous slide. Of course, compliance, DTAC, and everything needs to be assured. But I just want to show you one example of what we've done. So, thinking back to the previous slide around increasing patient demands and requests coming into the surgery, I just wanted to showcase one example of a use of AI in one of our surgeries or one of our products. So the Surgery Assist product is an automated assistant for patients. So it's a patient-facing product, encouraged to digitally enable patients. And you may have seen this in the market. So it just had a bit of a rebrand, formerly known as EDAT, but it's the same basis, same framework. So we're guiding patients to the right place. And again, more than happy, reach out if you'd like a full demo on this. But what I'm going to focus on now is where we're leveraging AI within the system. So at the moment, it's static. But some of the requests we got from patients and the feedback over the last 2 years of being in the market was actually patients just wanted to ask a question. So if I click ask a question, we obviously need to let the user know they're now entering the use of AI. Those, not to say skeptics, but patients that just want to know a bit more, if they want to learn more. We've then built in a very user-friendly AI guide to the digital assistant, and they can understand a little bit more, and we can ask them again, so would you like to continue, or basically, would you like to go back to the main menu? And I would like to continue today. And so what we're doing now is we're speaking to a large language model, which has been, it's narrow AI, it's supervised, it's controlled LLM, and I could do what everybody seems to be asking and ask if I can book an appointment. And historically, what your surgery would do, given the patient pathway and the view to access, would probably say, yes, submit an e-consultation via this button or this banner on our website. If you look at the data, 95% of website visits, users are just going straight to the big banner at the top of your webpage. So they're submitting a request straight into you. Actually, what the AI can do, if I say I want an appointment, AI can actually query them further and say, well, actually, what do you need it for? And I could say, I want to book, let's say, blood test. And I think this surgery, the way that this model has been trained, and I will say that all models are bespoke to every surgery. So if we want to book a blood test at this surgery, I believe we send them through AccuRx for this example, yes. But you could send them into, if you had any direct booking tool with a nurse, we could, of course, surface those links. And actually, while we're here, why not try that in Polish? So I want to book a blood test in Polish. And again, it's recognized it whilst we've trained it in English, it's recognized it and responded in Polish again. Let's try another quite menial thing, but patients want answers to these questions, and straight away it's recognized what I wanted to do. Now, better yet, one thing that we've done to train it, as I said, it's a supervised model that we're training it with. You may get a question where it may belong in the community. So what we can do is actually respond with a bit of empathy and actually signpost the patient towards a local food bank. Now, this goes for any community service you would like, whether it's bereavement care, whether it's mind blank now. I think one surgery we're working with at the moment, we've got 700 different services, but that stretches from community, PCN, pharmacy, of course, we've got pharmacy first protocols, and obviously into GP services as well. So last one, let's do one more. Let's do a different language. what time do you open in Spanish this time? And again, response in Spanish. So anytime,
Wow.
we can do that. Just looking at the clock, mindful of it. But at any time, so we're engaged with the AI. We're doing it in a safe way. The patient knows they're using AI. They understand where their data is. They've read the article. Of course, we've got privacy policies and things throughout that they can ask for as well. But at any time, I could contact the surgery with that button at the bottom, and I come out of the AI, and then I've got options to contact the surgery as I wish. So one thing that has been written up, I read an article yesterday on it, is everybody believes that AI is the answer to just block patients from accessing. It's absolutely not the right rhetoric, and that's not the way that it should be perceived. It's actually increasing and enhancing patient access, because not all patients need to be within the GP practice. Some of them belong at specialist services within the community, in the PCN, and we know that because we've got care navigators that are doing all that work themselves. But actually, if we could automate a large amount of that, we'd reduce the pressure on primary care pretty easily. And of course, reduce health inequalities, allow access for non-English speaking patients as well. So I've got one more minute just to go through the safety and where we do. So where does surgery assist sit? So we mentioned, right, that's how the AI works. That's how it's trained. It looks very safe. So where we envisage an automated digital assistant to be positioned is in front of your GP service. So all of this demand that's coming into you via the receptionist, via your online consultation tool, website forms, etc., you can add a layer of protection by allowing your patient to interact with a digital assistant first, and then looking at the data that we've collated, we can actually redirect, manage, or solve 30 to 40% of that demand. So to answer your question from the start, Lucy, there's a very simple example of how we can use AI to reduce that pressure on your practice team. There's a couple of things I just want to touch on, and the services that we use to develop this particular AI product. And I won't read them all out, but sentiment analysis that allows us to respond with empathy if somebody wants to give up something or quit. Natural language processing allows for typos. Translation is obviously languages. And it's just really important to note that it's locally trained. So we have a huge team that work with you as a surgery. You'd get your customer success advisor who would work with you to train your AI in a supervised way. It doesn't learn itself. It's not one of those agentic superhuman from the slides we mentioned at the start. It's all supervised and very narrow, but it's also very smart and very efficient. And all of our AI is rubber stamped by Futuristic, an independent AI consulting company, led by Dr. Keith Grimes, who was a GP for 28 years. So we've been working on them for the last 2 years to make sure this is all clinically safe and assured. And then around the architecture, again, I said I'd flash these slides up. I'm more than happy to have a more technical deep dive into a conversation around AI and how we've built it and we protect it. But it's really important to note, Exon Health has a 3H approach to AI. Our AI is helpful, it's honest, and it's harmless. And again, this is a widely known kind of application of AI or an approach to it, and it's certainly the one that we're adopting at Exon Health. So yeah, it's really important, and I hope that was beneficial for everybody. There's a bit of a whistle-stop tour in terms of what we're doing and where we're going, but I think it's really important to note that there's really simple, easy, and safe uses of AI to help ease that pressure.
Yeah, I think that's been brilliant, Max, and he's muted himself, so I'll speak fast. But as he says, if anyone wants to reach out and have a deeper dive into any of these things, Max is always active on LinkedIn and always available to chat, I'm sure. That is it from us today. If you have any questions, then do please pop them in the chat, and I will try and follow up in the follow-up email where I send out the recording. We hope you've enjoyed today. Thank you all for your participation. Our next webinar is planned for the 12th of February, where we're going to be looking to illustrate the shift in how patients access GP services with Exon's growing portfolio of products. Little bit of a mouthful, but I hope I've wet your whistle. And if I have, please look out for the link and sign up. It should be Max again, so it will be another in-depth tour, I'm sure. If you'd like any further information on anything we've discussed today or anything we haven't that you've got a pressing issue with, then please pop your ODS code in the chat, and we'll get the customer relationship manager responsible for you to get in touch. In the meantime, I'm going to make the recording available to all registered attendees in the next couple of days with all the relevant links as per usual. We hope to see you next month for more. In the meantime, from all of us here at Exon Health, have a happy and healthy January, and we will see you all again in February, no doubt. Take care of yourselves, and thank you.
Thanks all. Thanks, Lucy. Bye-bye.
Cheers, Max. Bye-bye.